Hello and welcome to the facts page of my YouTube channel. In this video, I'm going to be reviewing the most frequently asked questions that I receive over and over and over again from NP students when they round with me doing rotations in the critical care ICU that I work for. Some of them are clinical and some of them are more professional. Some of them are like broad perspectives on life, but as they relate to working as an NP, so I think you'll find them highly relevant. They're going to be in kind of no particular order, and I doubt I'm going to be able to get through it in one video or else you won't watch the whole thing, but we'll see how many we get through. And when I post this video, I'll probably list somewhere in the description down below what the questions are we will answer in this video to help you ascertain if it is relevant to what you need to know right now. If we haven't met yet, my name is Bree. I'm an RN, NP, mentor, interview strategist, and content creator. Welcome. Okay, let's start with probably, I know I already said this is going to be in no particular order, but let me go back up my word a little bit and start with probably what I think is the most common question I get, hands down. I think any NP out there would tell you this is what they hear the most from people. This is what I see people asking on forums. This is what most people are concerned about. This is probably the biggest concern that I had, and that is when you're going back to school to become an NP, I think in general we tend to underestimate how hard it's going to be in these programs and then how hard it's going to be getting out into practice, but you realize it when you get into school. So what happens is you go on these clinical rotations, you're massively overwhelmed, like what the heck, did I make a major mistake? And so the question you ask is, how long did it take you to get where you're at? Like, how long did it take you to get comfortable and then competent, or competent and then comfortable and then confident? I don't know how that works, but one of those three, any of those three, how long did it take you to get there? This is a natural concern. We all have it because we're overwhelmed. My answer to this comes in stages, right? Nothing in life is really, well, I won't say nothing in life. Most things in life don't just happen overnight. It is a slow, gradual process of getting there, so it comes in waves. It's sort of like if you have children. If you are a first-time parent and you come home with that precious little baby and you're like, oh, they're so cute, and the cute phase is kind of worn off and they won't stop crying, you're like, oh my gosh, when are they going to stop crying? When is this going to get easier? And you're just in that phase of just get through the moment, just get through the hour, just get through the day, just get through, and when is it ever going to get better? To me, when I reflect back on that period of my life, it was like at the 1-year birthday, right? You're having this big party, you planned, all these people are here, and you're suddenly sitting back for a moment and you're watching this kid who's probably starting to walk now, and you're like, okay, I can take a deep breath now. We have made it thus far, we have proven that we can survive, and we know how to keep growing and changing, and that's how it is becoming an NP. So I did make a video, I'm gonna put a link up here somewhere, there'll be a card where you can click on it, that talks about how to make that transition to becoming an NP a little bit easier because it's rocky. For me personally, it took me 4 months before I stopped white knuckling the steering wheel going into work. 4 months. And the reason that happened is because I finally learned how to automate work. I've got a bunch of other videos where I talk about how to use dot phrases, how to make yourself more efficient. Once you figure out how to make yourself more efficient when you're at work, you won't keep like spinning your heels. You'll start to slowly gain traction and start moving forward with your growth, your retention of information, and how quickly you can work and see patients. So definitely advise that you start creating dot phrases. I've got lots of videos on that as well. I cannot speak highly enough. That is probably the single most important thing that I did to make that transition easier for me. So 4 months till I wasn't white knuckling it, like scared to death to go to work because I might kill someone. 4 months. Then I stopped staying late, and it was probably like 6 months before I felt a little bit easier. It was a year before I thought I can take a deep breath. I don't have to look up every single thing that comes my way. I don't have to memorize evidence-based medicine. I've sort of got it, at least a foundation of it hammered into my brain so I can recall it pretty quickly. And then it's probably 3 years until you feel confident. At around 3 years, you're going to get to a point where you're like, I've seen pretty much everything that's going to come in for this specialty that I'm doing right now. Now, I sort of reset that clock when I go into another specialty because that's the thing about becoming an NP. You narrow your focus, you get really niched. And so switching from one thing to the next, you got to learn all the medicine for that new thing. You didn't go to medical school. You didn't get it all. You didn't get a broad overview of medicine like medical residents do, like physicians do. So you kind of start over. The difference is that now you know how to learn and you know what to expect. So it's easier the next time, but again, what you're learning and how comfortable, competent, and confident you are is going to be focused on what you're doing right now. Now, having said that, that 4 month, 6 month, 1 year, 3 year mark is going to vary based on what it is that you're doing. Okay, if you're in a very, very super ultra niched specialty, it's not going to take you nearly that long. I come from a place of learning ICU, intensive care, critical care. I think anything that's a broad overview of medicine is going to be like that, whether it's primary care, internal medicine, hospitalist, critical care. All of these things cover a very broad range of diagnoses. Now, if you're working for orthopedics, it's going to take you a while, right? Because you've got to know all the details that I, as a critical care NP, don't got to know. But it's very, very focused into one specialty, so you tend to see the same type of things more repetitively than I will in sort of a broad perspective field, if that makes sense. Okay. All right, now let's talk about a clinical question. One of the most common questions I get clinically, specifically in my field, is how do you choose antibiotics, or how did you learn antibiotics? I find this to be pretty universal. I have these exact same questions because I think in nursing school we aren't really taught about antibiotics. Now, we are taught kind of general overviews of these are different classes of antibiotics and this is what we give them for. But I don't know if it just doesn't really stick in our brain, or we don't really utilize that as a nurse. All we really focus on in our nursing experience is my patient has septic shock, they're on antibiotics, period. It's not necessarily which antibiotics are they on, what are they for, why is one better than another, how is it targeted, what are the side effects. None of that kind of stuff did I understand or even really spend any time trying to understand as a nurse. So when you suddenly have to do that as a provider, it becomes a little bit overwhelming. Calling all of you novice NPs who are getting ready to do your first rotation in the ICU and or your first job in the ICU. This commercial is for you. This is the one where I tell you about how I stopped staying late at work. It took me 4 months to get there. And what turned the tides for me was once I learned the power of writing dot phrases. Create a robust library of dot phrases in your EMR so that you can very quickly pull bodies of text into your note and just edit it so that it's specific for your patient. You're going to get very, very, very efficient at note writing when you do this. The other benefit of dot phrases is that you have access to information for things that you don't see very commonly. So reminders of things you need to check. Things that are very complicated like liver failure, all the different components of that, labs you need to check, diagnostics you need to do, treatments, what to talk to the family about, and you're like, oh yeah, I got it, oh yeah, I got it. So it's good reminders. It just makes you so much more efficient. And I have taken 11 of the most common of those diagnoses and put them into a book. So in this book, you're going to have these diagnoses with the template that you can copy and paste and put into your EMR. I've done all the work for you. You can edit it how you like it. And then there's a couple of pages of behind the scenes for each diagnosis. So pneumonia is an example in here. We're going to talk about CAP versus HCAP, the antibiotics that you choose and why you do what you do. So it's a little bit of a behind the scenes on what I teach my students when they do a rotation in the ICU. So if this would be a benefit to you, I would greatly appreciate if you would check out my website at briemp.com. There's an e-version and a hard copy I would be happy to mail to you. And if I haven't said it before, thank you so very much for supporting this channel and all the endeavors that I have. My whole goal in life is to help make things easier for you and be the mentor that I wished I had had. Thanks again. I, in my pharmacology class, was dreading the antibiotic section, dreading it. I think most NP students do. What helped me was Picmonic. There's an app called Picmonic. I think most people have heard about it. It is sort of a cartoon that is like sketched out in a video format, and there's a narrator over top of it, and it's trying to help use associations in your mind with visual stuff to tell a story so you can remember. Like there may be a broad class of macrolides that are discussed, and they'll have a story associated with it to help you kind of remember in your mind why you would choose it, what the side effects are, what the mechanism of action is, blah, 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 blah. That did help some. It certainly helped for studying for my tests, certainly did help a little bit with boards. But in reality, what I tell people is don't stress so much about this. What worked for me when it finally clicked was when I got out into practice and I started like reverse engineering my thinking, like working backwards Instead of trying to memorize all the classifications of antibiotics, all of those factors are the pharmacokinetics, all the side effects, all that stuff, I started memorizing common illnesses that I see in my specialty, and then what are the antibiotic choices that I have that will hit this organism. So once I started doing that, it started making a lot more sense. So talking about all the different antibiotics and what they're used for in the ICU setting even goes beyond the scope of this video, or it would take 10 years. Just know that for me, the best way I learned antibiotics was by focusing on my niche, what the common organisms that I see in my area are. There's something called an antibiogram that most organizations will put out. So region-specific organisms that you'll see, disease-specific. You know, if you're working urgent care, if you're working primary care, it's gonna be a different set of things that you're gonna be treating and seeing commonly. So just wait till you get into that profession and then start really honing in on understanding it. Okay, another professional question. What is the hardest part about being an NP? Almost every single student I've ever worked with has asked this question. I think it's a very good question to ask. You really want to know going into something what the downsides are, and we'll put another video up here about that because I've talked about that before as well. I think as long as you're informed going into things, it helps you to know what to anticipate and how you plan to deal with those challenges. For me, the hardest part about being an NP, number one, I would say probably far and away, is my I think how to say this without offending people is my sort of disappointment in how our profession has progressed over the years. I feel like the amount of appreciation, respect for what we've been taught to do, what we've been trained to do, what we're capable of doing has gone down a lot. I feel like our profession has been sort of watered down by educational institutions who are not doing a good job training NPs and who are really just looking to make money. They're pumping out NPs who are not prepared at all, but also boosting them up to think that they can do all these things that they probably can't and or shouldn't. And so it reflects poorly upon other NPs, regionally, globally, nationally, and it reflects poorly upon me. That is probably my biggest disappointment in being an NP, is the reputation that we have, because we are capable of so very much. And when you go to work for a healthy team that trains you well, that you have good communication with and good autonomy with, this can be an extremely rewarding profession to be in. But as an NP mentor, I talk to a lot of people in environments where things are not healthy. And it's very disheartening to me. So that's probably my biggest disappointment in being an NP. The second hardest thing, because this is a two-part answer to this one question, is now that I have been practicing long enough and I have worked for a team that has allowed me to practice with a good deal of autonomy, it's very hard to go to work somewhere where I'm not afforded that autonomy, where you go in and you're really not contributing much. You're certainly not contributing to even a moderate range of what you're capable of doing to your scope. It makes you feel just useless. And I think most people would say they would rather feel overworked and overused than useless. And so there are a lot of places that are kind of like that. So some people will say they're all right with those kind of environments, but I will guarantee you, if you ever go to work for a good team that allows you to practice to the full extent of your scope, it will be impossible to go back to not doing it. Another common clinical question that I get is, how do I know when it's time to intubate someone? How do you know? So there really should be a very objective answer to this. There should really be a strong, objective, evidence-based intubate at this point in time. But the reality is that's not quite the case. A little bit of it is gestalt. I hate to say it. In medicine, we really want things to be as objective and as outlined as possible, but there is an element of this is just not going to go well. But it comes down to your assessment skills and your ability to make that assessment and make a proper diagnosis, as well as prognosticate what the options will be if you don't intubate them or if you do. There's a lot that goes into it. As a person who works in a hospital that responds to rapid response calls, I have to make this decision a fair amount during the day, like how immediate is this respiratory failure issue and what are my options to do about it. So I've gotten pretty good at the gestalt. And I use the word gestalt because what I see in practice is that a lot of people, because we want to fall back on objective information, their immediate response to should this person be intubated or not is just, let's get an ABG. I really hate this answer, y'all. Now, an ABG is never really gonna hurt. It's just more pieces of information, but it's very rare that I make a decision to intubate on numbers from an ABG, because they're just numbers. You've got to look at your patient. So first, I think it comes down to assessing what they're doing clinically, and I highly advise you to develop a list of terminology that you can use to pick up the phone and call someone, a physician or someone, and say, hey, here's what I'm seeing and here's why I think they need to be intubated. So I love to just really get a good handle on your assessment terms. So things that will indicate that a patient is in respiratory failure, not respiratory distress, respiratory failure. So first of all, is it hypoxemic or is it hypercarbic? You're going to know if it's hypoxemic because you're going to see it on the monitor. You don't need a gas to see that. Now, hypercarbia is a different story. You do need an ABG to determine if someone is hypercarbic. But that alone, hypercarbia alone, does not mean it's time to intubate someone, okay? If the pH is normal, they're not confused, they're not looking like that they've got a CO2 narcosis going on, and they're not working hard, you don't have to intubate. Plenty of people with COPD walk around with a CO2 of 55 every day just fine. They don't need a ventilator. So if you have a normal pH but your PCO2 is high and they clinically are looking okay, you don't need to intubate. So is there a hypoxemic effect, a hypercarbic effect, or both? Okay, that's first and foremost. Secondly, why do you think this is occurring? Is this a pneumonia? Is this a pulmonary edema? Is this an apnea effect, like over sedation, or they took some drugs? Is this an airway obstruction issue? Did they aspirate? Is there something still in there? So getting to what you think is likely causing this effect is key, because some things can be dealt with quickly and some things are going to take much longer to correct. So getting to that, and then being able to describe what you're seeing. So if they're hypoxemic and you've escalated how much FiO2 you're giving through the nose, and then maybe you're considering putting a BiPAP on, and then they're failing it, then at that point you say, we probably need to intubate for hypoxemia. But outside of that, it's going to be a situation of worker breathing and how quickly can you fix the problem. Do we have heart failure? Is this somebody that his blood pressure is robust? I can diurese the snot out of them. I can slap them on a CPAP and help give that positive pressure ventilation to help reduce venous return, to hopefully help open things up with the heart, help it pump a little better, and maybe turn them around in 4 to 8 hours. It's reasonable that you don't have to intubate even if they look pretty bad. So this runs the gamut. Obviously, I don't have time to go through every single scenario in which I would intubate, but my takeaway here is don't just look at numbers on a piece of paper. Don't just look at an x-ray. Don't just look at what a patient's doing. Put it all together. Put all the things together and then make your assessment and present it to another person and make a decision about whether or not to intubate or not. It's a lot of different pieces of the puzzle. And eventually you will get so fast and efficient at doing this, you'll be able to get a gestalt about a patient within minutes of reviewing the patient and the labs and whatever you have in front of you. So you'll get there. Okay, it's looking like 4. I had time to get to 4 questions, guys. Sorry, I tend to talk a little bit, but I have a lot more questions I do want to answer for you. So maybe we'll just turn this into a series. So tune in next time when we get to maybe the next 4 common questions, and put some comments down below. If you want your question featured on here, put it down below. All right, y'all have a great week.